Bienvenue. Welcome to the webinar, The Friendship Bench, a community-based mental health innovation. My name is Monica Ruiz-Casares. I'm an associate professor of psychiatry at McGill University and coordinator of the Global Mental Health Research Seminar in the Faculty of Medicine. I will moderate this webinar. This webinar is part of a series that we launched 2 years ago with support from the McGill Global Health Program, the Quebec Population Health Research Network, and the Sherpa Research Institute. These multilingual webinars allow us to expand the training that is offered in the McGill Summer Program in Social and Cultural Psychiatry. Through these webinars, particularly, we hope to raise awareness of the mental health disparities around the world, exchange social, cultural, and critical research on global mental health, and build bridges across languages, sectors, and geographical locations. So wherever you're joining us from, we're very happy to have this space to share with you. Before I introduce our speaker today, let me point out a couple of important features of this platform to facilitate your participation. If you're joining us directly from your computer or the VoiceBoxer mobile app, notice that you can select your language of choice, English or French, at the bottom of your screen. Also, your microphones are all muted, but you will be able to send questions for the speaker at any time in any language using the general chat box underneath my image on the screen. You cannot, however, see the presenter or chat if you're connecting through a cell phone. For any technical issues during the webinar, you can contact the VoiceBoxer support team by clicking on the question mark icon at the bottom left-hand corner of your screen. Now let me introduce our speaker. Dr. Ruth Verhey is a clinical psychologist, a psychotherapist, and EMDR consultant and practitioner, co-developer of the Friendship Bench intervention that she will be presenting on today, and part of its management team. Her research focuses on easily accessible care for common mental disorders, community-based interventions, group support, the well-being of counselors, as well as PTSD in people who live with HIV. She has lived in different continents and in Zimbabwe since 2004. She's a researcher and a clinician, and we're very happy to have her with us today. Thank you, Ruth, for accepting our invitation. I will now pass on the floor to you.
Hello, everybody. Thank you, Monica, for inviting me. I'm very honored to be here. And thank you, everybody else, for taking the time to listen now or later. I'm very happy to be able to present my work on the Friendship Bench in Zimbabwe. And I want to start, if I get this all happening here, I want to start with a very famous quote. I can't do my, oh, this is what I thought. Okay, I'm with a very famous quote by now that there is no health without mental health. And I think we all know that, especially if we look at the fact that about 14% of the global burden of disease is attributed to mental health conditions, such as depression, anxiety, substance use disorders, eating disorders, psychosis, just to name a few. We all understand that physical and mental health are interlinked. They inter-influence each other. Someone who has bad physical health is more likely to have mental health issues and vice versa. And mental health issues, conditions, are often chronic and can be very, very disabling, especially so because people lack access to care or only get it very, very late. So luckily, this was taken up by the UN in the Sustainable Development Goals that were ratified by the membership states in 2015. And the global goal number 3 quotes really nicely that we are supposed to give prevention, treatment, and promote mental health and well-being. And that's really important. So the current global situation is really that mental, neurological, and substance use disorders are a leading cause of disability globally. There's about 1 billion people worldwide affected by one of these MNS, or more than one. As we know, there can be comorbidities. In many low and middle income countries, the infrastructure for care, for mental health care, is either not even existing or very poor. So people do not access treatment or don't even get diagnosed in the first place. And in Zimbabwe, that is very obvious. And if we just look at one very important part of mental health in depression leading to suicidal ideation, for instance, and suicide in general, the mortality in Zimbabwe is ranked at number 19 worldwide from suicide. So just to give you the background of Zimbabwe, so we are in southern Africa. You can see on the map, we are about 15 million inhabitants. And we have done studies, and over we found about 30% of those people who come to primary care clinics suffer from common mental disorders. That's the CMD. That is your depression, your anxiety, substance use disorders, PTSD. The HIV prevalence in Zimbabwe is around 13%. And luckily, many people are on antiretroviral medication. Nevertheless, more than 60% probably now, because we're in a very, very difficult situation socioeconomically in this country, are living below the poverty line. So what we see here, and what we see in many low and middle income countries, is that there's a massive treatment gap. So we reckon we have about one mental health professional to 1.5 million population. That leads to, as I said before, in our case, about 90% of those who would need care to go undetected and untreated. In the Zimbabwean psychiatric care system, we basically lack drugs, the professionals, the infrastructure in itself, and there is no low threshold access to care. Sorry, the slides are a bit slow sometimes. So this is where the friendship bench comes in. This is a person who is a counselor on the friendship bench, just to show you. We call them grandmothers, as you can see. There's some other with a client who brought her baby on a bench, in a clinic, in a primary care clinic. And there's another one of our ladies, of our grandmothers, who are all elderly ladies in Harare, interestingly enough. And I'll tell you some more. So what's more important in our setting, you will remember that I said that about 13% of our population are living with HIV, and consistently it is found that amongst people living with HIV, there are more mental, neurological, and substance use disorders prevalent. This also shows an association between non-adherence to the ART, for instance. So that means if someone suffers from depression, they're more likely not to take their medication properly, which is, in the case of such a lethal disease, in our case still, with such a chronic condition, a problem. So what exactly is this friendship bench? Some of you might have heard about it. We had a lot of media interest lately, which is very nice for us. So the friendship bench is a psychological intervention that is based on a cognitive behavioral therapy approach, the problem-solving therapy. We want it to be really, really low threshold, so easy to access for anybody. So it's offered at primary healthcare level. And it is a task-shifting approach, as we said before. So we work with lay health workers who are trained and supervised And shifting is something that is extremely common in our context. Just quickly, as I said earlier, we have a big lack of mental health professionals. The background of the Friendship Bench is as follows. It started in 2006 as a response to what was then called a cleanup operation that was carried out in order to remove illegal vendors and structures. And we estimate that about 1 million people were affected psychologically by this operation. People lost homes, people lost their businesses, their income, and just in general were also internally displaced. At that time, there was no mental health care offer in the public healthcare sector, and also a lot of people had no idea what they were suffering from could have been helped. So in our cultural context, what we call common mental disorders is more described with the word kufungisisa, which describes thinking too much. So that is the term in the indigenous language, Shona. And thinking too much often is presented with a somatizing aspect. So people might come to a clinic and talk about a headache. If they have a carer that has no idea about mental health and probably no time, they will probably leave with medication for pain. Furthermore, in our society, there's a big stigma for any kind of mental health issues and a lack of awareness. So people don't know what it is, so they don't know that there are treatment options, and therefore people do not seek help. And then, of course, if people do not seek help, conditions often chronify. You will know that. So when we talk about the problem-solving therapy in the Western approach, where we sit down with someone, where we ask a lot of questions, where we try to figure out, help someone to choose one problem to work on, brainstorm for possible solutions after having set a goal, and then coming up with an action plan, we have over time, and during those now almost 14 years that the Friendship Bench has been running, developed pretty much our own local approach to it. So step one would be kuvurapfungwa, which literally translates to opening up the mind, and that comprises these whole steps that I just mentioned. In kusimudzira, the uplifting bit, people literally get helped to find this plan of how to find the solution for their personal problem that they chose. And in Kusimbisisa, it is about strengthening them. Often the strengthening is in meeting their counselor again, which might, as we found out over time as well, happen in the streets as our counselors working where they're living, where their clients are living, and they're working where they're living. So this is a very community-based approach. We did a clinical trial in 2015 that was very successful and was published in JAMA. And just to show you just the quick key results is that we took a locally validated questionnaire, the Shona Symptom Questionnaire, the SSQ, that takes those local idioms of distress into account, and the PHQ-9 as well. And you can see there were significant differences between the control and the intervention arm. And just to highlight one thing, in the intervention arm, in 80% of those who had reported suicidal ideation pre-intervention, these suicidal ideations were reported to not be present anymore post-intervention. So we feel that it's definitely time for scaling up interventions for common mental disorders, depression, anxiety, and we have been learning a lot, and we understand that there's a high demand, very high demand for an intervention in our setting with the lack of mental health professionals and just that understanding of that people do need help. we have shown that the friendship bench is an effective intervention. We have also shown that it is feasible and cost-effective. And we have seen with what I described just now with the local idioms of the problem-solving therapy that it is culturally acceptable. In the last year, we have become part of the national mental health policy of the government in Zimbabwe. So we're very excited about being able to bring friendship bench into the whole of Zimbabwe. And we find it important because it is integrated into the primary healthcare system where it then becomes accessible to people. So what we do, let me tell you a little bit about obviously fighting the stigma through awareness campaigns, is we're using a lot of social media, we're using a lot of activities on the ground to get people to learn about mental health. And over time, while at the beginning people were still worried to be seen on the bench, we now have a lot of self-referrals. I might not have mentioned yet why it's called Friendship Bench. So after this cleanup campaign, there was this need to bring something in for people who suffered from the trauma, from the depression, but there was no space in the primary healthcare clinics. So literally, the only possibility we were given was that we were allowed to be on a bench on the clinic premises. This is where the term the friendship bench came from. And even now in the rainy season, they are trying to do the sessions on the bench with a bit of roof over them when they can find, or under a tree. It's definitely something that is very integrated and lived. And in the clinics, we have some of the grandmothers who work on the benches and where they do the counseling, and others who are doing what we call the mobilizing. So clients who come to the primary healthcare clinics will be told about mental health, and they will be told about that offer of the friendship bench. Interestingly enough, we also found that many of the people who come to primary healthcare clinics are indeed women. So this is a problem probably all over the world, that men's mental health seeking behavior is not the strongest. So hence we have to do even more awareness campaigns. We have one program, I jumped a little bit fast here. We have one program that we call the Youth Friendship Bench at the moment, where we manage to go out in the communities and work there, and we're actually finding that we can reach more men. Our community integration of the Friendship Bench is that we have not only the counseling on the bench, but we have something that we call the Circle Kubatana Tose, which stands for Holding Hands Together. It is a peer-led support group that is combined with an income generation component. Many studies have shown that poverty has a great influence on emotional well-being. And like I indicated earlier, Zimbabwe is in a complicated situation. We do suffer from inflation, and a lot of people have lost their buying power. And income generation is extremely important. So in the Circle Kubatana Tosi, we teach people how to make bags, often out of recycled plastic. In this feature you can see that someone works with VHS tapes, crocheting bags. Here you see many of them working together. And this group is voluntary. It is for those who have been to the bench. And we had hoped, and we see this happening as well, that people who have gone through similar experiences are able to support each other. We see often that there's big distrust, especially with that stigma that I was talking about, and people are not able or too scared to share what they feel. In our groups, we have found that people have become quite empowered by each other, learn to trust each other, And this is something that people from low-income countries can appreciate. In these groups, spontaneously, people have formed what we call mini lending schemes, where people basically share a bit of money every week, and one person gets it, and the next week everybody brings a bit of money again, and someone else gets it so that they can do their groceries. That is always a great base of trust to be able to do that. These groups have been running for many, many years. Often they don't even meet at the clinics anymore, but they might meet outside. They might help each other when they wait at the boreholes to pick up water, because many houses do not have running water nor electricity here in Zimbabwe at the moment. Here's another picture, and I think it's quite important to see that we also have men who come. Not many, but some. So it is about sharing, talking, which I think has always been important for many, many people, to come together, share ideas, talk, and feel connection. And that is something that we at Friendship Bench value a lot and find very important. And in all our tasks, we want people to understand that they're not alone. That is the only way to break stigma and to help each other. Like I said, especially with the HIV setting, many of the people who come to clinics are people who live with HIV, and we did a study as well where we found a very high prevalence of PTSD amongst those living with HIV. And there it is very important to help calm down and be joined and connected. Although we've had now many years of HIV awareness and campaigns and support, there's still quite a stigma around this condition, and it is seen as something that is shameful. Hence, people will hide and need support in safe spaces that Friendship Bench tries to offer. So interestingly enough, we think that Friendship Bench is extremely sustainable in the Zimbabwean setting, as our counselors are part of the healthcare system. As I mentioned earlier, they're working in the communities they live in. And often people think that our Friendship Bench counselors, these grandmothers, as you can see here, are doing nothing but Friendship Bench work. That is far from true. They actually are employed as health promoters, so have many, many other jobs. And when we started to train them, the most difficult thing for them was, as they live in a society where the elders will have the knowledge and are asked for advice, is to stop giving advice. All of you who know what problem-solving therapy is about, is that definitely we're not about giving advice. So our grandmothers were very excited once they understood that advice giving was not what was wanted from them. And when they started to understand that, they kept reporting how amazingly that enhanced their other work as well, which is around treatment, like treatment adherence, recommendations, for instance, bringing people to vaccination drives for babies, etc. So many times grandmothers told me as well that it helped them with their personal life, with their own families. We did research on their emotional well-being, as I was worried about them living in the same environment as their clients, thus being exposed to the same stressors as their clients, often having chronic illnesses like diabetes or hypertension themselves. And we found that the prevalence of depression, anxiety, or PTSD amongst our grandmothers was remarkably low. We explain that with partially the point that they do a very fulfilling job, that they, as we all know, benefit from helping someone, and that they are very, very well recognized in their societies, in their communities. They are seen as respected elders. They have the authority to literally go to someone's house and hold a home visit with that person, a home session. They're allowed culturally to ask all sorts of questions, which means that brings us back to how important and how feasible task shifting approach can be in the care for common mental disorders. I think this task force of community health workers or lay health workers is extremely important, and we should leverage much more on those and help them to grow their skills. So it's really important for this future generation that is growing up, especially in such stressful times as here and in many other places in the world, that they see that mental health is becoming something that is always important, that is regarded as real, and that there's care, that there's treatment availabilities. Like I said earlier, we don't often have medication available. And we feel if we can all help people to become more aware of mental health and how it's being helped and strengthened, we can prevent a lot of problems and a lot of chronic mental illness, common mental illness. So I think that's about it from my side. Thank you very much. Please do visit us on social media. Tatenda, I'm handing over to Monica.
Thank you, Ruth, for candidly sharing your experience with the Friendship Bench, an intervention of great interest on itself, and that may spearhead others to follow up on similar interventions with lay workers in resource-poor settings. In the time we have left, we are going to go through some questions. To all the participants, you can send me messages through the general chat box. We will be compiling and adding those to our list. So I will ask a question and then pass the floor back to you, Ruth, after I formulate every question. I hope that works well. Okay, let me start. As the name of the Friendship Bench indicates, we see that the bench is also an important aspect of the intervention. Bench seems universally available and accessible, but to what extent does it have to be a bench? Or in other cultural contexts or environmental conditions where people may need more private space, could it be something else? For instance, could it be a tea room? I'll give the floor to you, Ruth.
Thank you. What a great question. It does not have to be a bench. You can sit on the floor. You can stand somewhere. We actually were thinking about that as we are branching out. So we have the Friendship Bench already in neighboring countries. We're in Malawi and in Zanzibar at the moment, and we get a lot of requests from all over the world. And that comes up as in how is it culturally acceptable to sit on the bench in a public space? It hasn't been an issue in Zimbabwe. It hasn't been an issue in those two other African countries, Southern African countries as well. I think in the Western concept, the idea of privacy and the fear around confidentiality issues is very, very big. Not to say it is not big here. It just seems that people just are more accepting of whatever is possible. It is really the only measure we had. It can happen anywhere. The only thing that we at Friendship Bench find really important is that it is low threshold. So people do not have to do a lot to find help. I hope this answers your question. So wherever we go, we try to make it very, very accessible for people so that people, and we know that whoever has been through therapy themselves, it takes great courage to go to a complete stranger and open up. And so we want to help by making that really easy. Going back to Monica.
Thank you, Ruth. I'll just ask a quick follow-up to that. So are the benches located, the photographs you showed, seem to be always taken outdoors, but are they located always in public view, or are they somewhere else? And a second follow-up, can you tell us in what other countries besides Zimbabwe the friendship bench has now been explored or established? Thank you.
Okay, so in our setting, the benches are all more or less they are all on the clinic premises. Sometimes they might be behind the clinic, so not immediately visible. Sometimes they are very visible from the moment you walk onto the clinic premises. Like I said earlier, in the beginning, it seemed to have been more of a, like, let's hide the bench, let's put it in the furthest corner of the clinic premises. And by now it seems to be more open. And we have some clinics who have a little bit of a space, like a roof, for instance. And sometimes you have 2-3 benches under that same roof with 2 or 3 sessions going on at the same time under the same roof. Something that is hard to imagine, but possible. And so we are currently operating in Malawi. We are operating on the island of Zanzibar that belongs to Tanzania. And I haven't mentioned that yet. The Friendship Bench also exists in New York City, which is really exciting. So they adopted our concept in New York City to, again, like I said before, to make mental health access really, really easy. And yeah, so that people can get help without big problems. And I know that in the West, often maybe we have many psychologists or psychiatrists there, but getting access to them is also very complicated. Back to Monica.
Thank you, Ruth. How is it possible for community health workers to distinguish thinking too much, which requires clinical attention, for instance, depression, from thinking too much, which does not?
Wonderful, thank you. That's a fantastic question. So we are using a locally validated questionnaire, the Shona Symptom Questionnaire, and we have taught our community health workers, the grandmother, in using these questionnaires at the beginning of the session. So that is basically their screening tool that they use to assess where someone is. So it's a screening tool that determines the risk for having depression or general anxiety disorder. And if someone is at great need for higher level of care, for instance, there's a question that asks for suicidal ideation, then there's a very succinct referral pathway, and the lay health worker will take the client to the clinic nurse, and if that needs to happen, they will even be referred on to tertiary care. What we found over time is that, like any therapist will confirm, the longer they work, these grandmothers, the more experience and skills they get, and we have found that they have handled a great deal of suicidal ideation themselves. We train them in that as well. So the training is a manualized training that gives them basic mental health literacy, counseling skills, like the self-care, the whole setting around how to be with someone, open questioning skills, etc. And we're really, really proud to say that the lay health workers that do this job really well are handling an enormous amount of cases, and even more difficult cases, really well by now. Back to Monica.
Thank you, Ruth. The study shows the effect of the intervention after 6 months. Sometimes the problems that cause thinking too much are not personal, but are more structural, such as poverty or discrimination. In that case, thinking too much may be recurrent. The program has an income generation component, you described it, but how do you see the long-term effect of the intervention? To what extent and in what way can the effect be retained?
Thank you. Great question as well. So ideally, as we know, when we talk about problem-solving therapy, is that we want people to be empowered to learn to help themselves. That sometimes we might think that's a natural and people can do this, but sometimes people have to learn it. And as we know, when we suffer from depression, our cognitive thinking skills are not the best, and we might just not get it right. And we now learn a skill with the help of someone who is coming, like literally what we say, these grandmotherly skills. She has time. She will listen patiently. She is going to be there. She was trained in being non-judgmental. And that seems to create this human-to-human connection that helps people to be able to learn. We always encourage people to come back. Sometimes there are clients who come back for many, many times. In the study, we put down that the average friendship bench intervention comprises of 6 sessions. Often we found that people do take less. Some others take more. In terms of ongoing effects, you're very right, especially when there are a lot of external stresses that are continuous. We can only look at the study. At that time, we only were able to follow up for 6 months. We get reports from people who come back in later and say they're feeling great and that helped them a lot, or they come back and say, I have another problem that I want to work on, or they bring relatives or friends, which we think is a great thing. That means that people feel that this is helpful and they want to refer others to it. So we would love to have a long-term follow-up. That would be fantastic. At the moment, we are focusing on a few other studies at Friendship Bench. We're looking, for instance, at, and this is an external stressor, like the comorbidities with NCDs such as diabetes and hypertension, and to see how they can help each other when people also get the Friendship Bench support, and what differences we can make there. Like I've mentioned, the Youth Friendship Bench. We're also looking at a rural component, or a rural Friendship Bench, where we adapted a little bit to the rural setting here in Zimbabwe, which is very different. About more than 60% of the population lives in rural settings, and often it is subsistence farming, and especially now as another stressor, we're looking at climate change, which is real here in Zimbabwe and can be seen. That will have an effect on people's subsistence farming, and therefore on their mental health when yields are not going to be as predictable anymore, or the rains are not coming as predictable. And so there's a great need for looking, doing more research, which we definitely want to do. Back to Monica.
Thank you, Ruth. Just to follow up, do you ever recruit caregivers among the people who have received the intervention? And also, do people always meet with the same grandmother when they go to the bench if they receive more than one session?
Thank you. Great question. So what we're doing right now, as we noticed, this is going so well, and it is happening even outside the clinics as well. We've actually started to train people in our intervention who come from the community. And it is our dream to have the Friendship Bench everywhere within walking distance for anybody. So because, like I said earlier, there is quite a stigma about going to a clinic, as it might be associated with seeking HIV care or whatever. So like quite some groups of the population do not want to be seen at the clinics. So it is our dream to have the Friendship Bench available in community areas, community centers, centers like places of worship, wherever it is. And that's exactly what we're doing from now on when we roll out in Zimbabwe. So we will be in the primary healthcare setting all over Zimbabwe, but also try to get into more and more communities so it's more reachable for more people. We do train people who have been part, who have come through the friendship bench themselves before, and we see great benefit in working with people with lived experiences on that level. So we're very excited, and like I said, the groups, the peer support groups, are really run by peers, so there is already a lot of exposure to working with each other and helping each other and using the friendship bench approach with each other as well. So watch the space. We want to train a lot of people. We want to be out there and reach a lot of people and hope that a lot of suffering from common mental disorders will decrease more and more over the next years. Back to Monica.
Thank you, Ruth. You've described this being a manualized intervention, but how have you trained, how have the community workers that you have trained been supervised? So how do you make sure the fidelity of the assessment and the therapy which they provide to the local population?
Thank you for that question. So the supervision functions in the following way. The system of having community health workers in the primary healthcare setting is basically structured in a way that they have a superior here in Zimbabwe. I don't know if that's in other places maybe similar. So, and that superior was trained in the intervention as well, and we rely on them seeing their community health workers regularly. Plus, we have in pretty much every clinic that we are in, one community health worker who has been part of the trial, which means she had much more training, and as it is in a clinical trial, much more support at that time. So she is more experienced in the work and has become sort of what we call a community health worker supervisor. So there's a peer supervisor component. So where they have regular meetings on a weekly basis and discuss cases. Then there is their direct superior, and then there are friendship and team members who regularly visit the clinics as well to see what is going on in order to make sure that data collection is happening and whatever needs to be done is happening. Back to Monica.
Thank you, Ruth. Community health workers are crucial to scale up the intervention in low and middle income countries, and particularly in such places where they are unpaid. Their altruism is essential. To what extent can the intervention provided by community health workers be feasible in urban areas where maybe such altruistic attitudes may or may not be found?
Okay, so yes, I agree. I think task shifting is an important component that has to happen. Luckily, in our setting, people are employed and do get an allowance for their work, so it's not volunteerism here. And I think that's an important discussion anyways, to have how much we can rely on these kind of works being done by people who are volunteers. My one discussion that I often have with people is when we work with community or lay health workers and we train them and we give them a lot of training, when do they stop being lay health workers? When do they become specialized health workers, basically, even if they don't have the formal training that someone had who comes in on a different position? So not only do we have to look at the safety for the counselors with their skill set and the using of their skill and the supervision and the ongoing training, we have to look at the motivation. So what always comes up is that incentive. What are the incentives for people to work in this position? I don't know, can we do this with younger people? Is that a viable job to raise a family from in the long run? I think there's much more that we have to all discuss, and that healthcare systems, ministries of health have to really look into as well when we want to follow the SDGs, especially SDG 3, and offer successful, cost cost-effective, efficient, and accessible mental health care worldwide, everywhere. Yeah, back to Monica.
Thank you. So you described the RCT that you led as very successful. Can you please discuss more about what made this study successful, which may be useful information for studies of similar interventions and or in other settings?
Okay, I don't just want to say the study, that clinical trial was successful. I think what is important in this context is that we actually managed to scale up, and that is something that is rare from what I have seen. So maybe people manage to do a clinical trial, but the scaling up business then is not happening. And I think we need to put a lot of effort not only into proving the effectiveness of a concept, but also finding out how can we then put what we've proven into place that's actually being used. So I know when we look at clinical trials, there's always that discussion that a clinical trial will have a whole lot of effort happening to it, which is not absolutely representable of the reality. And after a clinical trial, is it really happening that way? And we are currently also doing an implementation study around the friendship bench implementation since our scale up in 2016, and that will be very interesting. So we're like halfway into our study, so we're really looking forward to having more data coming out and then publishing on that one. One thing, there was that word mentioning earlier about fidelity of an intervention. It is interesting to see, okay, we want great impact of an intervention, but at the same time, we want fidelity to be really high. At some stage, something has to give. We have to work with acculturation, maybe, if I can call it that way, an adaptation. Something has to live and grow. Like I described earlier, that we started out with the Western concept of problem-solving therapy, and we're now at the point where we say we've got a Zimbabwean version. We've got a Zimbabwean adapted version. It's still, the concept is still the same, but we're calling it differently. For us, it is lived differently, and it's organic in that way. So I can just encourage people to when they think of an intervention and they test an intervention, to also right away think of what are the ability, or what is the possibility to scale it up so that it actually really reaches people. Back to Monica.
Yes, thank you. You've mentioned people's concern about being seen in the bench space, particularly when the benches are placed in clinics. Can you expand on how the bench is perceived locally, and what ways are you using to combat the shame you described and the stigma associated with common and not so common mental disorders more broadly?
Mm-hmm. Thank you. So I think it's important, and the good thing about the bench is that a bench is literally just a bench to sit on. So whatever happens on the bench is a different story. So people might just be sitting on a bench and be seen as we're talking here. Some people, like I said, are seeking out the lay health workers in the communities because they don't want to be seen on the bench, but many people are happy to be seen on the bench. It is, to our knowledge, the more awareness campaigns we are doing and the more we kind of talk here and train the lay health workers to bring this awareness into their communities, the more we learn that people are very, very willing and very looking forward to being heard and being able to tell their stories. It really is a lot about encouraging people to open up so that they don't have to carry their stories by themselves. We haven't measured the stigma as such in Zimbabwe, and maybe we should be doing that. Maybe one of the future research components. I mean, we definitely all learn there's only that much time in a day and many days in a week, etc. But we feel like just from the responses that we get from people, and especially also from younger people, that there's a great interest in learning more and being heard. And that's, I'm just coming back to the Youth Friendship Bench study that we're doing at the moment. And this is going to be a component. This is the same concept. It's just that it's delivered by younger counselors. So we're moving away from that concept of the grandmother, the elderly person who has maybe a lot of wisdom, but also learned not to just give advice, but to speak. And we think that is entirely happening outside of the clinic setting, and it's very, very welcome in young people. And so we feel there's a great branch of the Friendship Bench that is growing here at the moment to reach the newer generation, the younger generation, to hopefully grow up with better mental health. Back to Monica.
Thank you, Ruth. Can we say that what is shared in the bench stays in the bench? If the grandmothers come from the community where the people that they meet with come from too, are there issues of confidentiality and privacy an issue in that context? What have you learned about different understandings of privacy in that context and how to handle it?
Thank you. So confidentiality is a very important aspect, and even if I mentioned that it doesn't seem to be top number one for people, of course it is. It's just that I think a lot of us here are just taking what we get, you know, and if it's we're sitting close to someone else, then that's what it is. We like in the training, in the Friendship Bench intervention training, confidentiality is a very, very important point, and it comes up with people. We trust that our grandmothers have understood that very, very well, and we've never had reports as such that confidentiality was broken or at some form abused in any in any form. And we believe that people will get the experience of being heard, being taken seriously, and feeling understood in their plight, that gives them that good experience. So again, watch our space. We have a few publications, or we have a few studies with future publications coming out on all of those processes as well that we're looking into. So that will be really interesting. But just from what we're hearing, confidentiality is being taken care of and respected, and people feel they're being taken seriously. Back to Monica.
Thank you, Ruth. We have time for maybe 2 questions more. Caring for others can take a toll on caregivers. You just talked about confidentiality and keeping what is discussed on the bench. So following on the previous question and your earlier comment also about peer supervision, can you please explain how the program supports the care and well-being of grandmothers who provide support to others? You mentioned incentives, but any others and any advice that you can share for other task sharing interventions in Zimbabwe or in other contexts for the care, the self-care and the care of the grandmothers?
So again, I'm very big on self-care, and we make that an important part of the training as well. So interesting, what we call the circle Kubatana Tose has become like a structural item of Friendship Bench. Like in our team meetings, we do a CKT where we sort of check in and share with each other. And I find that amazing how it changes people when we actually also start talking about some personal stuff. We encourage grandmothers to look after themselves, to exercise, all these kind of things. And because they have been working together often for 30 plus years, they have very, very strong relationships with each other. Also interesting, sometimes we say these grandmothers don't like move, they stay. So like I said, there seemed to be a protective part for them to have grown and be so rooted in their communities that they are literally known. They are well known. Like I said earlier, they when they walk down the streets, people know who they are. And I think there's also a protective factor for them, at least that's what they say, is that they first of all have seen and heard a lot of things already, and they've also seen and heard a lot of solutions already, you know, even if they like it's not their place to tell someone to do, oh, why don't you do what the other person did, but they have sort of kept this hope. Another thing that is definitely a case in Zimbabwe is it's a very religious people, and there's a protective aspect of that one as well, lots of spirituality. And in general, the grandmothers keep telling us that they enjoy their work. They feel they're being taken seriously and they are respected in the work they are doing, which seems to be very important for them. Of course, we could always do more, and we're trying, even if it's just that if they could get more pay, for instance. That is a different story altogether. Yeah. Back to Monica. Thank you.
Thank you. That's a good segue for the next question. You mentioned that community health workers in your program are employed, but how did you make it possible to employ them? Are they paid by the government health budget? And if so, did you negotiate with the government by showing the evidence of the study, or how did that come into being?
Okay, thanks. So we are really in that lucky situation that the lay health workers were there before we came. So like I said, they are health promoters, as that's what their job is called, and they were working in that job already for the past 30, 40 years many times. So when Zimbabwe became independent, this primary healthcare system, a really good primary healthcare system, was set up with these different levels of care. And so they are paid by in Harare, it's the Harare City Health Authority, and in the other municipalities that is similar. And so everywhere in the country, there are community health workers that are paid by, well, basically the authorities, the government in a nutshell. Yeah. Obviously, in low-income countries, those pays are not very high. And therefore the difficulties, the socioeconomic difficulties that everybody goes through here are noticed by the lay health workers themselves as well. Back to Monica.
Thank you, Ruth. Just time for one more question. You mentioned that grandmothers are the community health workers who provide the problem-solving therapy. But how can men's involvement, such as grandfathers, is there any specific reason to have grandmothers, and how do you see the role of gender in scaling up the intervention?
Thank you. I love that question. That often comes up. So interestingly enough, we are currently in 2 other cities in Zimbabwe as well, and we do have some grandfathers there. So personally, I like this whole aspect, that discussion very much, because I think it is a little bit dangerous, and if we are too traditional and we think only grandmothers can do this job, or there's some female thing around having this empathy and this talking skill and stuff. We definitely have trained, when I said we trained people from the communities, men amongst our young counselors, there are lots of men, and obviously we want to branch this out. So like I said, the coincidence that there are only women in Harare at the moment, in the capital of Zimbabwe, is really because these were employed in these positions 30, 40 years ago. We would love to have as many people, and I can just repeat this, all over the world, to be trained in simple talk therapy, strategies, basic skills around open questionings, knowing how to listen, properly listen without telling someone already before that person has really spoken to the end what we think and what we want to do. And we just, one of our dreams would be if this becomes like curriculum in schools, and people just grow up with talking to each other, and literally to each other, not at each other, and learning to taking the time to listen and recognize and validate each other in whatever experience people are having. Thanks. Back to Monica.
Thank you, Ruth. We're now coming to the end of the webinar. It was a very informative presentation and conversation. And it was also lovely to hear the birds and the green trees now that we're buried under the snow here in Canada. So a brief evaluation will be sent to the email address that you registered with. Let me see if we can have this information for you here. You can copy the URL and paste it, or just respond to the email you'll receive. It will take less than 5 minutes to complete and will help us greatly as we plan future activities. Also, the recording of the webinar in English and in French will soon be posted on the websites of the McGill Global Mental Health Program and on the webinar pages of other sponsors. You can see the logos at the bottom of the slide. Thank you again, Ruth, and thank you to all of you for your participation. I wish you a good end of your day and a bright 2020. I hope that you will join us again next month as our webinar series continues. Take care.